Welcome team, Sean Heverson here. We're going to be finishing up our nervous system lecture for the anatomy for the paramedic by reviewing the peripheral nervous system and its structure. Let's go ahead and get started. So we started off our discussions with the function of a neuron. Then we zoomed out a bit to look at the central nervous system, both looking at the brain and then the spinal cord structure. And now the last bit of that is the peripheral nervous system. So the central nervous system is consisting of the brain and the spinal cord. As we can see here in this picture, on the left-hand side of the picture, it's got the central nervous system identified, and the right-hand side, peripheral nervous system. Now, a common misconception is that the cranial nerves are part of the central nervous system. And though they're branching off of the brain and the brainstem, they in fact are peripheral. And we'll talk about what that actually means in just a moment. When we think of the peripheral nervous system, though, the peripheral nervous system is essentially the connection of our brain and spinal cord with the outside world and the inside of our body. That's not brain and spinal cord. The ganglia are connections between these nerves. So there is a physical connection between the central nervous system and the peripheral nervous system. It's a point where the central nervous system's nerves branching off the spinal cord, for example, for the spinal nerves, are going to have a terminal axon that will release a neurotransmitter that crosses over the synaptic cleft and communicates essentially with the receptor portions of a nerve, the receiving neuron. If we're going from the brain to the rest of the body with our efferent pathway, that receiving neuron is going to probably receive the signal through the ganglia, where the dendrites are then depolarizing and sending their signal through to whatever the organ is. For the most part, we focus on the peripheral nervous system because that's where a lot of emergency medicine drugs work. And medications that are working on the body already at the EMT basic level will have an impact on the big three, or sometimes we refer to them as the big five. The big three being the brain, the lungs, and the heart. And the big five being those three plus the liver and kidneys, all organs that we really can't do without. So in total, we have 43 pairs of nerves. We've got 12 pairs that are branching off the brain and the brain stem, and 31 pairs that branch off of the spinal cord. In our previous videos, we saw pictures of a dissection in which a vertebrae was cut in half to reveal the inside of the nerve and show the vertebrae intact and all of the nerves branching off. In this picture, you can see the nerves are actually shown to be branching off, but just imagine that they're actually in between the points where these vertebrae are connecting to their intervertebral discs. As a reminder, our afferent division or afferent pathway is going to have a signal being sent from outside of the central nervous system towards the brain. And usually that would be considered a sensory tract. And our efferent pathway is going to have an effect on some other organ. So those are generally our motor neurons, even if they're not communicating with an area like where we would consider locomotion to occur or motor neurons occurring in our skeletal muscle. So again, here's that picture mentioning earlier. We've got the spinal cord right down the side here on the left of the picture. And as we're looking at the collection, what is presenting as this dull yellow color, that's going to be the actual vertebrae. And they've been cut so that with a bone saw so that we can actually see this through dissection. What we're seeing here are some of those dorsal nerve tracts or roots that are extending from the spinal cord and now going on to another region of the body. And these big bulbs here are the ganglia. So this is our central nervous system now branching and connecting at the ganglion to our peripheral nervous system. So one point in which this would bypass transmission up the spinal cord and into the brain would be our primary reflex center. So reflexes, as we recall, are a connection with, at the simplest, a sensory neuron communicating from an environment or outside of the body on our surface of our skin back towards the spinal cord, and then directly connecting from that axon to the dendrites of a neuron that's motor control and sending out a signal directly to skeletal muscle without us having to receive it, and the time it takes, even though it's microseconds, the time it takes to send that impulse to the brain, process, and send back again. So the reflexes can be as simple as 2 neurons or could involve a third neuron in the interneuron, which is another neuron that's in the spinal cord but again serves to connect the sensory and motor neurons, or affector and effector neural pathways. So the big divisions of the peripheral nervous system include the cranial nerves and the spinal nerves. The cranial nerves you will be memorizing. The spinal nerves, the 31 of them, have different functions throughout the entire body's system. So some of them will be relevant to us in emergency medicine at this level, and some of them will not. They certainly could be reviewed for extra knowledge. But at the very basis, we're going to have to understand how spinal nerves communicate with our major organs throughout the body. The cranial nerves are going to communicate branching off of the cranium and following along the surface of the cranial vault, communicating with areas of the face, the neck, and the upper portion of the shoulders. The spinal nerves are branching away from the central nervous system by extending out in between each vertebrae. So we can consider them branching directly off of the spine, hence the name. So that should help give rise to their name and memorization tools that will help us identify them on a picture if we're presented with it. Now, when you learned about the vertebrae, so we'll talk about vertebrae first, and then we'll talk about the spinal cord. When we learned about the vertebrae, you learned about the major regions of the vertebrae. Within the neck, we have essentially 7 bones, the thorax 12, lumbar 5, and then the sacral and coccyx fused together to create essentially one large bone. So a memorization tool, if you're trying to just kind of dust off your NC basic knowledge, a memorization tool used to be, and still would be relevant for the vertebrae, though not necessarily the nerves. For the vertebrae, we have 7 cervical vertebrae extending from the vertebrae at level C1 at the top, and that's generally how we'll count vertebrae from the top down. C1 is up here connected to the base of the skull, and then C2 below it. C1 and C2 come together to allow major head motion around the spinal cord. And that head motion is dependent on each of those 2 vertebrae being free to move. The first vertebrae, C1, is sitting directly underneath the area where the foramen magnum opens up inside the skull and allows the brainstem to convert then into the spinal cord and exit the skull. That's considered the atlas. So you can use C1 and atlas for the same terms. And essentially thinking of Atlas as mythology, Atlas was holding the world on his back. So this one vertebrae, which is actually particularly small compared to some of the rest of the vertebrae, as we extend down, vertebrae get larger and wider. So this is one of the smallest vertebrae. It's holding the entire 8-pound or so cranium and brain right on top of its shoulders. Just below it, C2 is C2 or axis. So we have atlas and axis. When we think of the term axis, we're talking about movement around a single point, and that's kind of the axis. The axis for us would be the spinal cord. So movement for the C2 or axis vertebrae is essentially around as I'm moving the laser pointer. Imagine that being front and back, so it's circular as we turn from left to right and rotate our head. The up and down motion, a lot of that comes from atlas or C1. Then we recede down, and our vertebrae would extend from C1 to about C5. C5 and C6 is where one of the most important sets of cervical nerves is going to be exiting. And that cervical nerve is going to be part of the cervical plexus and involve coordination with our breathing through the intercostal muscles and our diaphragm. That's why, as a new EMT, you probably learned something along the lines of C1 through 5, stay alive. If they have an injury above the level of vertebrae 5, then that will cut communication with all other nerves below it if the spinal cord has been transected there. And that means that they won't be able to move their arms and legs, and they won't be able to breathe under their own power. But if they have a spinal cord injury that's between level C6 and below, they may become a quadriplegic, but the difference being that they would be able to breathe on their own, because if the cut is here and the phrenic nerve is branching away here, the phrenic nerve is still communicating with the brain. Okay, so C7 is a physical landmark for us, and C7 is located as one of the largest when we're looking at a body surface, not the presence of a drawing or an x-ray. When looking at the body surface, it's one of the largest projections where the back of the vertebrae is pointing out just about the level of our shoulders. And so you can find that, orient yourself, and the next bone below that will be T1. We'll go through T1 through 12, and then the next bone below level T12 will be L1, and we progress downward as we go. So in that control, the importance of these different nerves are certainly of utmost importance to the patient if there's an injury or an illness associated with them, but they'll mean quite different management styles for us as emergency medical providers. The last thing I'll point out here, too, is right through this region here, we have the quadratus equina. So that would be in the lumbar, where the terminal end of our spinal cord has been reached and starts to branch off to communicate with the lower extremities through nerves like our sciatic nerve and other nerves coordinating the internal region of the pelvis and its organs. Now, when we talk about the nerves branching out of the vertebrae, we have 8 cervical nerve pairs, and those are going to extend right at the level of C1 and then branching and extending between C7 and T1, hence 8 pairs when we have 7 vertebrae. And we'll continue extending. Notice the pairs of nerves that are extending at the thorax are basically riding along the edge of our ribs. The costal bones, or our ribs, are going to have a bundle that we'll talk about a little bit later in the trauma course, and that bundle is going to ride with nerves, a artery, and a vein right underneath the edge of the rib bone. And that's important to know because at some point we may have a patient that needs to have a procedure, which we commonly call in the field a DART procedure, but its technical name is going to be a thoracentesis, in which we place a needle through the anterior or the axillary region of the chest, and we're going to go right above the top edge of a rib so that we can get the needle into the pleural space inside the chest cavity and decompress when the person has a pneumothorax. If we were to inadvertently push that needle through along the bottom edge of a rib bone, or if we went too far above the rib bone that we're trying to skirt on the top of, then we might actually injure the nerve and injure the blood vessels in that region, making it more difficult for the patient to breathe and contributing to their loss of blood if they already have one. More on that a little bit later, but that's where our bundles of nerves and blood vessels will travel underneath our costal bones. Here's another picture highlighting, again, we've got the picture of our dorsal nerves exiting a nerve root or ganglia, and then this is technically where our peripheral nerves begin. This is central nervous, ganglia, and peripheral nerves as they extend. Okay, we've seen this picture before. This is essentially the same picture we looked at in the central nervous system and spinal cord lecture, particularly when we were talking about the meningeal layers around the spinal cord and the brain. So we've got that H pattern of gray matter in the center of our spinal cord. We've got the spinal canal right in the center of that where we'll have circulation of fluid. And then we've got the posterior and anterior roots of nerves extending out. We can see that we've got our ganglia, and that's listed here, sympathetic ganglia, located, and they travel along the length of the vertebrae depending on whether we're looking at sympathetic or parasympathetic nerve cells. Okay, in a few slides, we'll actually talk about the spinal nerves as they branch off of the vertebrae, and we'll communicate with the peripheral nervous system divisions of sympathetic and parasympathetic as a subdivision of the autonomic nervous system. The cranial nerves are our point of memorization on the peripheral nervous system. This is one of the largest and hardest bits of information in a single portion of the peripheral nervous system to start memorizing. The education guidelines at the paramedic level from the Department of Transportation do require that we cover these and that they are memorized through the process. Now, you're going to see these again in a few different places. You'll have a discussion of them in trauma next semester. The following semester, you'll have discussions of the cranial nerves in the nervous or neurology lecture, and there may even be some discussion of it later in your 4th term as well. So when we're looking at the 12 cranial nerves in this picture, I think it's a pretty good representation. This would be the brainstem turning into the spinal cord, and you can see it's got that small H pattern right there in the middle with our gray matter. And just below this level here, we'll start branching out into our spinal nerves. So the cranial nerve function, some of these nerves are going to have communication that goes in 2 directions. Some will have communication that's only sensory and others that's only motor. And at this level right now, I don't necessarily need you to memorize that degree of information about them, but I do need you to know the names, the numbers, the major function, and how to test all of these nerves. They'll become part of our advanced neurology assessment, and they have very distinct roles. Some of those roles will give rise to diseases. For example, the trigeminal nerve, or cranial nerve number 5, communicates with the face and has a role in sensation sending back to the brain. Now, this can produce an infection that originates inside the trigeminal nerve, and that infection will cause burning on often one side of the face. And that burning sensation is basically the infection stimulating the sensory nerve to depolarize and send a signal back to the brain where it's processed as actually pain. Now, we're going to be assessing all of these cranial nerves, and one of the more common sets of cranial nerves that we'll assess have to do with eye movement. We'll assess eye movement in trauma and in presence of major illnesses like stroke or things like retinal detachment after trauma. So in memorizing these, as mentioned, you want to be able to say cranial nerve number 1 is, in this case, cranial nerve 1 is the olfactory nerve. Its function is to send sensation from the special sense of smell located at the upper portion of our nasal cavity and communicating backwards along the base of the skull to the base of the brain. There's a number of tools out there to help you memorize the cranial nerve, essentially the order and the first letter of the actual name of the cranial nerve. If you memorize the order, then you'll know which cranial nerve is number 1 versus number 3. And if you can memorize the first letter in an entire order, then you should be able to get the specific 1-word or 2-word name from that nerve. So it doesn't matter to me which song you use out there to try and identify and learn the cranial nerves. Let's talk about the nerves associated with eye movement here for a moment. Now, the eye movement may be very specific. So, for example, when we talk about the oculomotor nerve, the oculomotor nerve is going to be responsible for pupillary constriction and dilation. So that one nerve generally has kind of one major role. But other nerves, like our trochlear nerve, are going to communicate with more than one, as you can see here, more than one, and as well as our abducens, more than one specific muscle, contracting and relaxing so that we can have multiple planes of movement. The way that we identify and test this is by using the 6 cardinal gazes and drawing an H pattern. So imagine my laser pointer here is placed directly in front at the level of the person's eyes, right in front of their nose. And this laser pointer, that would represent using a thing like your finger or a pen or pencil and having the patient follow. Ask them to hold their face still so they don't turn their head to follow your movement of the pen, and only follow the movement of the pen with their eyes. You're going to be observing how their eyes move in all of these planes, and we make an H pattern. So let's say that we'll put it right here. This is the center of their line of vision. I'm going to move all the way to either the left or right. Here I'm starting on the patient's right, all the way to the right where the peripheral field is, and then I'm going to move up and look at the corner movement, move straight down, look at their down corner movement, back to the center line, go all the way across to the other side, end of the peripheral field, up, all the way down, back to center, and return. Now, in doing that, you're looking at these points. You're looking at their ability to focus here, their ability to focus straight at the plane line, to go up into the corner, down into the corner, and do the same thing on the opposite side. And so in that movement, we're actually coordinating the movement of all of these muscles, which aren't 360 degrees surrounding the eyeball. These muscles have different points of attachment and coordination with the eye socket to give rise to that movement. So that means that some of these nerves will cause some contraction in one muscle and a small amount of contraction in another muscle to reach that end. A good hint, though, sometimes can be the actual term that's used. Here, this term, abducens. Abducens gives rise to eye movement that's associated with the lateral range. So if we think of our movement of body parts, just movement of limbs, when we hear abductor and adductor, ADD versus ABD, abductor is basically moving away from the core, and adductor is adding the limbs to the core. That will make more sense when you see it as a picture in your textbook. Now, as that movement occurs, abducens is basically describing abductor motion. It's hard to get those things straight sometimes. So in total, the nerves that are associated with the eye, then including the optic nerve, which is where our sight is going to be pushed all the way back to the sight region in the back of the occipital portion of the brain, all of them together will make up nerves 2, 3, 4, and 6. Now, the 5th cranial nerve is actually branching out and communicating with the face as the trigeminal nerve. So that covers quite a few of the nerves through that order. So the olfactory nerve, number 1, communicating smell and the sense to the region of the brain, somewhere around the hippocampus. We've got nerve 2 as our optic nerve. Then 3 and 4, both communicating the movement of the eye and the pupil. 5 as our trigeminal facial nerve, major sensory role. And then 6, our abducens, also communicating movement with the eye. Now, the facial nerve, number 7, is going to have motor control, which is why we're highlighting the muscle in this picture, with regions around the eye, the cheek, the face, and the upper portion, the superior portion of the anterior neck. Now, with that, we can take a pause here and start thinking about where you've already assessed some of these nerves before. You just didn't know it. Well, think of if these muscles are contracting, that could turn a person's straight, flat face, stoic face, to a smile or to a frown. It could cause elevation of the muscles that cause the eyebrow to elevate on the forehead. And so that can give rise to a lot of our expression. Think of when we've asked patients to show us an expression in their assessment. Well, when we do the Cincinnati pre-hospital stroke scale, we ask patients to do a few things like to smile for us. We observe the presence or absence of things like drooling, and we'll do a few other things with some spinal nerves and cranial nerves as we assess as well. So essentially, when you ask them to smile, you've had them do an assessment that will give rise to any issues of our facial nerve. And notice when somebody has a stroke, often one side of their face can function and the other side cannot. And so that helps identify that our cranial nerves are basically split as hemispheres, just like the control of the rest of our body. Okay, so that's the facial nerve number 7. The vestibulocochlear nerve has sometimes a few different terms associated with it, all except either one of them, but they basically both have to do with sensing auditory sound movement of the structures of the inner ear. That's also going to have a big role in things like our proprioception. As we've talked about before, proprioception is essentially knowing where in our body, where our body is relative to space, other objects, and parts of our body relative to our trunk, like our limbs as well. So that's the 8th cranial nerve. Cranial nerve number 9 is right here, glossopharyngeal, involved with coordination in the hypoglossal, which is the 12th cranial nerve. Both of these are going to allow the person to swallow. Now, this isn't something that is common for us to ask our patients to see if they can swallow, but it does have big airway risks. How we'll see this, though, as we're just assessing our patients in the very beginning, if a person is having a hard time swallowing, whether it's because of pain, like we have in a child in epiglottitis, or because of muscle function dysfunction here, often the rise of a stroke, as present, then the person won't be able to swallow the normal secretions we make of saliva. And so saliva will accumulate in the mouth and the person will have to spit it out, which is difficult if these muscles aren't working, or they end up drooling. So drooling as an assessment for stroke is essentially an assessment of our glossopharyngeal and hypoglossal muscles. Now, the vagus nerve isn't something that we generally can ask the patient to do or make a direct observation of on the outside of the body. The vagus nerve is our parasympathetic primary nerve, and that's branching off of the lower regions of the brainstem and then communicating with our parasympathetic nervous system. The vagus nerve is responsible for all sorts of mechanisms within the body, from areas of our GI tract and controlling gastric motility rates, the function of our stomach and liver, and communicating with our heart. If the person is experiencing a situation in which the parasympathetic nervous system is most dominant, then their heart rate and likely their blood pressure and force of contraction of the heart's ventricles will decrease, giving rise to low blood pressure and often bradycardia. So that's when the parasympathetic nervous system is essentially winning on our balance between the sympathetic nervous system. The sympathetic nervous system, as you can see, doesn't actually have branches located here. We'll explore that a little bit more as we talk about where the parasympathetic and the sympathetic ganglion are branching off of the spine. The first clue, though, is that the parasympathetic nervous system's branching starts off in the cranial nerves. Finally, the last nerve that I have not discussed is the accessory nerve. Although it's not the last nerve, it's number 11, hypoglossal is number 12. The accessory nerve is responsible for movement of our major neck and shoulder muscles. And so when I say shoulders, what I'm really talking about is the trapezius muscles connecting to the neck. So an easy way to assess this is to have your patient, while they're seated or standing, you place your hands on their shoulder and you ask them, both sides being monitored, to shrug their shoulders. If they can shrug their shoulders, that's usually a pretty good sign if their shrugging is equal. If the shrugging is not equal, we'll have to explore that a little further. We also may want to assess the movement of the neck along the cervical spine by asking the person to turn their head to the left and to the right, just against a little gentle pressure from our hand on their cheek. So that if my hand is on my patient's right cheek, I'll ask them to turn their face into my hand, and I'll compare that with their movement of turning their left cheek into my left hand. This is a table that's out of your textbook, the Thibodeau textbook, and it basically lists with its other section of the table all of the cranial nerves, their cranial nerve number, the impulses, and the major functions associated with it. So that'll help you in aiding your memorization. Okay, that's the cranial nerve. So you got a lot on your hands trying to memorize that. But let's add to it, why don't we? So when we're talking about spinal nerves, we commonly will have a bunch of nerves together that make up a branching called a plexus. The plexus or plexi are going to be branching off of different areas of our vertebrae and have names that may tell us where it's branching or where the nerve is going to, or that plexus is going to. Now, there's a few plexi inside the body. Most of them we actually will not spend a lot of time memorizing, but we do need to memorize a few. Recall that we talked a little bit about the spinal cord branching off and communicating with the rest of the body. We talked about the cervical plexus and the brachial plexus. Now, those are important because those will give rise to sensation and function of the upper extremities, and specifically the phrenic nerve communicating with, as a branch of the cervical plexus, communicating with the patient's or ours intercostal muscles and diaphragm for breathing. Again, if that's severed, if communication is cut from that nerve to the brain, then the person will not be able to breathe on their own and is at risk of asphyxiation. So as listed, here's our two plexi that we'll want to focus on. Now, what I'm looking for is knowledge of where these are branching off and their major role. This has actually, brachial plexus has a tie-in to our trapezius, which will have some control through our 11th cranial nerve. We also have anastomoses with our accessory nerve and our hypoglossal nerve. So both of these plexi are going to communicate from the spinal nerves that they originate as back and communicating to areas controlled by our cranial nerves. This is a picture of our cervical plexus branching then and communicating with our diaphragm muscle, as we can see here, stretched across the inside of the chest cavity of the thorax, and further communicating with our intercostal muscles through this region here. So we can also see a few other nerves in this region, but we're going to follow basically the phrenic nerve down, buried through, and eventually exits and communicates with the diaphragm. We can see that's called here our phrenico-abdominal branch of the phrenic nerve. The other nerves here are important and play major roles in the body, though they aren't nerves that we'll generally need to memorize for our exams. The spinal nerves are extensions of the axons that move through the brain, down through the spinal column, and then communicate with the peripheral nervous system and the rest of the body. So the spinal nerve, as a peripheral nerve, it begins within the ganglion that we have pictured here. So remember that our ventral root, most of the ventral root neurons and nerve tracts are going to be motor axons, and most of the dorsal root, though not all, there's a few exceptions, are going to be sensory axons. We have along the lateral portion of the spinal cord on both sides a combination of some nerve tracts that are both motor and some nerve tracts that are right next to it that are sensory. Now, just as we did throughout our other discussions of the nervous system, at some points we do need to discuss some major illnesses that aren't necessarily common for the EMT basic level of knowledge, but do have to be covered in the paramedic level of knowledge as we treat patients. So for our peripheral nerve disorders, one of the nerves or a condition that can have a few different specialized regions to this condition is neuritis. So breaking down this term, this looks very similar to neuron, so it's referencing the actual nerve cell itself. And this reference, itis, the itis, is referencing some type of inflammation. Now I want to make an important distinction here. Itis doesn't actually, when it's presented, always reference an infection. That's something that we kind of misidentify from our lay person knowledge of these terms. Itis is going to reference inflammation, which sometimes is associated with an infection. So let's change our thought process on itis to reference inflammation. And sometimes that inflammation is because of an infection. So in this case, the neuritis examples that we have, the first is sciatica. We talked about sciatica in our spinal nerve discussion for the central nervous system, in which the nerve branching off, going down to our lower extremities from our spinal cord, truly part of our peripheral nervous system, is the sciatic nerve. And sciatica's inflammation specifically of that nerve, in which excruciating pain for the patient that's experiencing this can develop, and they feel often a feeling of pain shooting up their leg and can be the result of low back injuries. In fact, I used an example in one of our discussions of a paramedic friend of mine, firefighter, who's still practicing thankfully today, but has sciatica because of a back injury sustained while kneeling next to a patient during cardiac arrest and trying to pick up a Life Pack 12 at the time, and off balancing their load, slipping the disc and causing pressure up against the spinal cord and the nerve. Another term here we can break down. So we have so neuron, and algia. So neuralgia, the algia portion of that is referencing pain. So neuralgia is pain associated with, in many cases, the junction between nerves and muscle. Specifically, trigeminal neuralgia is that condition I was referencing earlier, in which recurring episodes of burning and stabbing pain along the branches of the fifth cranial nerve across the face is sensed by the patient. Now, since the cranial nerve extends on both sides of the patient's face, it could impact one and not the other, or impact both in rare cases. Another condition that could involve our cranial nerves is not necessarily associated with pain, but can have some numbness associated with it, is paralysis of the facial features that arise in the face from our seventh cranial nerve. Bell's palsy is a presentation in which often on one side of the face, the patient's motor control will diminish as they have a recurrence or a flare-up of their Bell's palsy. If that diminishes, the face loses its tone that the muscles would have from the communication that the neuron is providing them to provide facial expressions. So without that contraction of very small muscles in the face, one side, if the other side is not affected by this, will droop and the other side will remain with some tone. If the person is asked to smile, they will not be able to on the affected side, which can present very much like the facial presentations of a stroke. Now, it's difficult sometimes to tell if this is a Bell's palsy first occurrence, or if the patient is suffering a stroke, or if we don't know their history and they can't communicate with us at that point in time because of their illness. When in doubt, we'll consider that it's a stroke until proven otherwise. Things that could help us, though, identify that Bell's palsy is the culprit and not a stroke. One of the first things to notice is Bell's palsy doesn't affect the rest of the body. So Bell's palsy is specifically of the face. So all the other things that we would have in our Cincinnati pre-hospital stroke exam, like pronator drift when we ask them to put their arms up, and the grip strength when they squeeze our fingers on assessment, like any neuro exam, would appear probably normal in a case of Bell's palsy. It is possible that somebody has a stroke to the blood vessels that are feeding just this area of nerve cells, and in that case, it would present very much like Bell's palsy. In any case, these patients are at risk for Bell's palsy, at risk of things like aspiration and inability to eat and feed themselves when they have flare-up of their disease. Many patients know what their flare-up is going to look like, and some will actually report that they have a sensation before the flare occurs. Another illness, in this case an infection, that is associated with the peripheral nervous system is shingles. Shingles is an infection of the neurons within the skin following along the length of dermatomes. We'll discuss those in just a moment. The dermatome that's inflamed will present with herpes lesions developing on the surface of the skin, and often, because this is associated with nerves, the patient will experience a prodrome in which they have a sensation before the pain and visible presentation of the vesicles on the outside of the body present themselves. Now, this is associated with the chickenpox virus, which is known as herpes zoster, and the chickenpox virus in this case has found its way and lives inside the dorsal root ganglion and remains there, dormant, as listed here, not active and not showing signs and symptoms until the person has an episode of shingles. Shingles often can be brought on by physical illness or stress, and can also be brought on by things like topical surface burns, like a sunburn, causing damage to the surface of the skin and inflaming the areas around the dorsal root ganglion. So in the case of the presentation, this could be on one side of the body or follow a single dermatome. So let's look at what a dermatome is. Dermatomes are very useful in medicine, and it helps the person that's assessing a patient with really just a limited set of assessment tools help identify where, if the person's experiencing a presentation or pain on the surface of their skin, which spinal nerve is communicating with that area of the skin. Now, this could also be useful if the patient has no longer communicated with the dermatome and they have paralysis, in the case where maybe a spinal cord injury has occurred and spinal shock is ensuing. In that case, something that you already know about, spinal shock, the patient that has an injury, say, at this level, would have a clear line of demarcation in which all of the blood vessels below that level of injury of the spinal cord are going to vasodilate, producing a flush red appearance below the level of injury, and above the level of injury, they'll vasoconstrict to make up for the loss of blood pressure when all the blood drains due to gravity. That line that we talk about, that demarcation line, would follow, essentially, if it's a complete cord transection at that level, it would follow the dermatome. If you identify the dermatome that's associated with the injury, the presentation, or the pain, then you'll be able to understand which nerve may be infected or injured in the process of the patient's initial injury. Now, for us and our purposes here, it's important for me to state, if we require anything of you from dermatomes, we will provide you with a dermatome chart. Now, a dermatome chart would be helpful to have in the field because in the field, as this will present, it's very difficult to just look at someone and know where the dermatomes are expanding. So as you follow these, in this picture, it's very easy. All of our purple dermatomes are thoracic, the blue are cervical and cranial, and then our red and pink are going to be associated with the lumbar and coccyx and sacral communication. So in the case of a patient that's having an episode of shingles, they'll have inflammation that follows along at least one of those dermatomes. And that would present as a line of vesicles that are breaking out. And as it follows that one dermatome, which could involve more than one dermatome, as it follows that one dermatome, that's showing exactly where the herpes infection is occurring. In this case, herpes zoster. The peripheral nervous system is always monitoring outside and inside environments of our body and relaying that information back to the brain for processing, in some cases bypassing that and communicating directly with motor neurons in the case of a reflex. Now, once the brain has processed the sensory information it's receiving, then it can have an effect on the rest of the body. So we use the same terms here, affective and effective fibers, to communicate with the CNS as we do with the peripheral nervous system. Now we come to the heart of this discussion. All of that information was to prepare us for the knowledge that we're going to apply in the field associated with the division of the peripheral nervous system following the track down to the autonomic nervous system. So the peripheral nervous system branches at first into two major divisions. First, the autonomic division, and on the other side, the somatic nervous system. So the somatic nervous system we won't spend a great deal of time talking about, but when we do talk about it, it will have some relevance to our emergency medicine. The somatic nervous system is generally thought of as being associated with conscious and voluntary control motor impulses that are often communicating with skeletal muscle. There are sensory impulses as well from the body and our cavities communicating back to the central nervous system. Though I won't talk much about it now, in the future, when we explore the skeletal muscle system, we're going to talk about the somatic nervous system in the coordination between a neural junction and the motor neurons in the muscle that are receiving the signal to contract. Now, this will be especially relevant not just for normal function of the body, but as a paramedic, you'll have the unique and very dangerous opportunity to place a patient into a paralyzed state by using medications that will block impulses through the somatic nervous system with the muscle, and resulting in a patient that cannot breathe on their own, but it would facilitate our intubation. That's in a process called RSI, which is technically termed rapid sequence induction, not intubation. Rapid sequence induction is a sequence of putting the person into the paralyzed, sedated, and pain-free state. That occurs rapidly, but your intubation needs to be as methodically as possible so that you can have success on your first try. It is not rapid sequence intubation. There is another process, though, rapid sequence airway processes, in which the patient is going to be partially sedated so that an airway can be achieved, and often that won't be with an ET tube. More on that as we explore intubation of the respiratory system later in this semester. The autonomic nervous system, though, branches into two more divisions that are of note for us, and this is where you probably learned most about the autonomic nervous system at the EMT basic level. So this is the division of parasympathetic and sympathetic nervous system. On this picture here, before we get into those effects of the two divisions of the autonomic nervous system, I want to highlight the actual structure and the anatomy of this system. So we've got here in the central picture presentation of our spinal cord that's been dissected, and we have the H appearance of our gray matter surrounded by the white matter all around it. Specifically for the terms we're talking about right now, the origination of the neuron is going to be within the ganglion of the cell bodies at the center of the spinal cord. Now, as we communicate, the central nervous system then communicates with the peripheral nervous system by reaching out and communicating with the ganglion. We have sympathetic ganglion and parasympathetic ganglion, and further we have areas that are pre-ganglionic and post-ganglionic. Well, what that means is if we're talking about pre- and post-ganglion, we're talking about we're talking about neurotransmitter crossing over from the synaptic cleft to the receiving cell. In this case, that receiving cell is also another neuron. So the neurotransmitter that's communicating across this space from the central nervous system to the peripheral nervous system changes depending on whether we're talking about before the ganglion or after the ganglion. So the terms that we're going to be using will be preganglionic sympathetic neurotransmitter, postganglionic sympathetic neurotransmitter, preganglionic parasympathetic neurotransmitter, and postganglionic parasympathetic neurotransmitter. The neurotransmitters that we discussed in the central nervous system are still important here, but we're going to focus mainly on two, and those two probably to some degree were discussed at the EMT basic level. The two neurotransmitters that are responsible for the autonomic nervous system at this level are acetylcholine and norepinephrine. And for right now, it's okay for you to think of norepinephrine very similar to epinephrine in its role. We'll think of that as our adrenal or our sympathetic neurotransmitter. And for the most part, you probably learned that the acetylcholine neurotransmitter is responsible for parasympathetic response. To a degree, that is true. Well, where it gets a little funky here is in the pre- and post-ganglionic neurotransmitter differences between our sympathetic and parasympathetic nervous system. Let's start with the parasympathetic nervous system. The parasympathetic nervous system communication is primarily with major organs, and that branching, as you recall, occurs at first when we have our our cranial nerves branching away from the cervical vertebrae at the level of the neck. So we have a specific term for the parasympathetic nervous system that's associated with this location. So the parasympathetic nervous system's ganglions are going to branch off of the spinal cord at the cranial and sacral regions of the body. Let me say that again. We branch off at the cranial. We know that because of the cranial nerve number 10, as our vagus nerve being a parasympathetic nervous system major transmitter. And then we also have branching off at the sacral region, at the very bottom distal end of our vertebrae. In between, we do not have parasympathetic ganglion branching off. In between, in the thorax and the lumbar region, we have sympathetic nervous system ganglion, and sympathetic nervous system does not branch in the neck or at the sacrum either. So parasympathetic, we'll come to see in a picture in a moment, is going to be considered craniosacral, and the sympathetic will be thoracolumbar because of that. Okay, back to our neurotransmitters. So as we branch off and we're communicating, our parasympathetic nervous system is going to have a preganglionic, meaning from our central nervous system to our peripheral nervous system, neurotransmitter of acetylcholine. The parasympathetic nervous system also uses acetylcholine at the point of communication with the neurons and axons that are communicating with the organ. Let's use the heart as our example. So acetylcholine will be released for the parasympathetic central nervous system axon, crossing over to the dendrites of the parasympathetic peripheral nervous system axon, and it will also communicate from the peripheral nervous system axon to the heart. Acetylcholine in both cases. That's pretty easy, right? Well, the difference and an area of confusion could come from the area that the preganglionic, central nervous system to peripheral nervous system, sympathetic neurotransmitter is also acetylcholine. The epinephrine, in this case it's really norepinephrine, the epinephrine that you have associated with the sympathetic nervous system is the postganglionic neurotransmitter. So of the 4 neurotransmitters, 1 for each sympathetic and parasympathetic, 1 on each side, pre and post, for a total of 4 neurotransmitters, 3 of those are acetylcholine. That helps also to give rise to the idea that acetylcholine is the most abundant neurotransmitter in our body. So when the sympathetic nervous system is communicating with the norepinephrine, in this case, the adrenal gland-driven neurotransmitter, that's going to be communicating directly with the organ. In our purpose, it's the heart, but it could also be the lungs and blood vessels and other organs throughout the body. So let me say that again. Our parasympathetic preganglionic neurotransmitter from central nervous system and peripheral is acetylcholine. Our parasympathetic postganglionic neurotransmitter communicating to the organ is also acetylcholine. The sympathetic's preganglionic neurotransmitter is acetylcholine, and the sympathetic's postganglionic communicating with the organ neurotransmitter is norepinephrine. Okay, excellent. Now, you may have to work on that a few times, but that will help us understand the process of communicating with the organs, of which we actually hack a bit when we use medications to do something like elevate the patient's heart rate or cause bronchodilation in the lungs in the presence of asthma. So in this picture here, I really like this picture to highlight the idea that the sympathetic and parasympathetic innervation or communication with our organs originates in different regions of the spinal cord. So as we see here in blue, all the stuff that's in the blue color is parasympathetic, and we have branching in the cervical and the sacral vertebrae. That will communicate with internal organs throughout the body, including in between the cranial and sacral, but we don't have parasympathetic branching from the area of the thorax and lumbar. That's sympathetic. In this color of, I guess, pink, if you will, the sympathetic nervous system is branching from the sympathetic ganglion chain, which is a chain of ganglions communicating with the spinal nerves throughout the thorax and the lumbar. Now, this will be really important to understand for a few conditions we're going to talk about next semester. It will help tell us a little bit about the different conditions that occur when patients have spinal cord injuries, especially around the level of T6 through T12. More on that later, but understanding this will make it much easier then to understand. Now, a challenge for you in the peripheral nervous system, specifically this section, the autonomic nervous system, is to make sure that you know what the response is of all of the organs in this picture if the parasympathetic nervous system is dominated or the sympathetic nervous system is dominated. You can see that they are opposite of each other, but in the past, at the basic level, you were probably only challenged with identifying the sympathetic and parasympathetic communication with major organs like our heart and our lungs. But it's so much more than that. And what we do with our patients has impacts on the rest of their body. To some degree, as a paramedic, you may have to weigh the impact it has on other organs and the impact that you're trying to achieve. All right, so this is just a restatement of our autonomic nervous system ganglionic, preganglionic, and motor neurons, highlighting that, again, the preganglionic neurotransmitter for both nervous system sections, sympathetic and parasympathetic, preganglionic, is acetylcholine. Okay, so another term that we haven't actually had the liberty of using so much in this course just yet, that we'll hear a lot about, is visceral. So before we get into this slide here, let me just define visceral. Visceral is generally referencing communication with an organ or the outside of an organ. When we learned about the membranes of the body's cavities a few chapters ago, the membranes include a lining that's on top of an organ, like the outer surface of the lungs. That's something we may be familiar with from our pneumothorax learning at the basic level. And then we have an opposite, not visceral, but now the inside of the cavity is lined with the parietal membrane. So when we hear visceral, we can take that to mean, especially when we're talking about membranes, that's probably where we'll most often use that term. When we're talking about the membranes, that's the membrane that's covering the organ itself, the abdominal organ, the lungs, the heart, whatever it is that we're referencing, and the cavities lining is going to be parietal. All right, so autonomic or visceral effectors are going to communicate with some of our smooth muscle and some of the glands in our body, so hence the organ is relevant to this term. All right, I basically stole the thunder from all of these slides here. You're welcome to read them as you need to, and pause the video to review the text that's here. Okay, now we're going to jump back into the nervous system here by talking about the sympathetic nervous system. Now, receptor sites are throughout the body, and there's many different receptor sites for different portions of our nervous system and different organs that we have in our body. But the two receptor sites that we use the most often in very emergent conditions are associated with the sympathetic nervous system, and the medications that we give are specific often or not specific, meaning they will touch on both of or multiple types of the divisions of these receptor types. So we'll need to know these so that we can learn future medications. Now, at the basic level, you probably didn't have a lot of medications that were going to be truly alpha specific. So that might be a little bit new to us. But let's start with beta, because that shouldn't be new. At the basic level, you learned about beta receptor sites and should have learned something along the lines of beta 1 versus beta 2. Beta 1 autonomic nervous system receptor sites are associated with beta 1 associated with one heart, because we have one heart, making it very easy to memorize. Beta 2 is associated with the lungs. We have two lungs in a normal patient. Now, alpha has receptor sites 1 and 2 as well. Right now, I'm going to focus, though, on alpha-1 receptor sites. Alpha receptor sites for this purpose in emergency medicine are associated with smooth muscle, specifically smooth muscle that line the inside of our blood vessels. Now remember, the term for constricting blood vessels is vasoconstriction. It's not necessarily arterial constriction. And folks wonder why that is sometimes. Well, when we learn about the cardiovascular system in a few weeks, we're going to learn that the veins and arteries both have muscle within their inner lining, but only the arteries have a large mass of muscle that causes profound constriction when activated. Veins can constrict to a very lesser degree because the lining of muscle inside the veins is very much smaller than the arterial. So when we think about this, we'll have to balance this a little bit with the condition of the patient. At the basic level, we learn kind of 1 + 1 = 2 in the sense of if I see this, I do this, and I get a result from it. So you learn probably that if I need to manage the patient's asthma attack, I want to cause, in the emergent session, I want to cause bronchodilation to open up those constricted bronchi that are communicating with the lungs so that we can get more air movement. And that's basically reversing what was happening during their event. Well, we learned albuterol is a very good tool for that in most patients. And albuterol generally is going to have, in low doses especially, a major effect on beta-2 receptor sites more than beta-1. So that means that when we give albuterol, especially when we're giving it through the inhalation route, it's going to have, in small doses, an impact on the bronchi and not so much to do with the heart. But as the patient starts taking higher doses of albuterol, those higher doses will start to activate beta-1 receptor sites, and they can get symptoms like palpitations, tachycardia, anxiousness, increased blood pressure, and some of those, the ones responsible for communication with the heart, are activated even though we think of it as a beta-2 drug. So sometimes when we're learning the medications, we're going to have to learn a few different types of classes for them. In this case, we're talking about albuterol. And albuterol generally would be termed as a adrenergic agonist, meaning that it activates the adrenergic receptor sites. Adrenergic is in reference to adrenaline, and a layman's term for epinephrine is adrenaline. So when we're talking about the sympathetic nervous system, it can be also called a sympathomimetic if it causes the sympathetic nervous system to work harder. Then we can specify whether or not it's a selective drug in selecting only alpha, only beta-1, or beta-2, or non-selective in which it will activate multiple receptor sites. Now, epinephrine is another drug that's used for the sympathetic nervous system agonist, and in that case, epinephrine is going to be useful in all of these areas. It's non-selective, but it is a sympathomimetic. If we're having to stop a process, in this case of the nervous system, then we'll use the term antagonist versus agonist or sympatholytic. So in those terminologies, we're basically saying if it's a sympathomimetic, it causes the sympathetic nervous system to kind of turn up, essentially. It's not really off, turn up. And if we're using an antagonist, we're turning it down. Well, the terminology is important because at the paramedic level, we no longer are going to be able to think in the terms of if I see this, I do this, because often, as you probably learned if you're practicing in the field, it depends. Most patients don't read the textbook, as we say, so their symptoms aren't and their diseases aren't as simple as the category of the disease that we've described or the category of drugs that we've described. So you're, as a paramedic, now going to be tasked with, hence all this training in anatomy and physiology, tasked with making decisions for that specific patient and their condition at that moment in time, and not necessarily for their disease. Because what may work for that disease in most patients may not work well for that patient's condition with other diseases and other medications that you're faced with dealing with. So it will be important that you recategorize those EMT basic medications, and you look forward to medications at the paramedic level that will be associated with the sympathetic and parasympathetic nervous system. Now, a question sometimes for those who have done some advanced reading is, where are the muscarinic and nicotinic receptor sites? Well, those come up especially as we're talking about control of a few different things, but for us, control of the movement of skeletal muscle. So we'll talk more about those a little bit later in the pharmacology course and in discussions on specific nerve body systems, organ systems here in this class. But for this level, they won't be relevant for right now. So remember, at the basic level and at the layman's level, we learned some terms for sympathetic and parasympathetic. And those terms are actually pretty useful for us, and they're going to help you in memorizing and applying on your exams this information. So just to recap, our sympathetic nervous system was known as the fight or flight response. And I've said that before. And when we're saying fight or flight, we're really saying your body's making that decision. Do I fight for my life in the presence of maybe a bear or a lion chasing me, or do I run? Do I flight? And when you're doing that, you have a split second to make that determination. And while you're doing that thing, fighting or running, you're going to need all the blood going to all the muscles in your body so that you can keep them strong and supplied, as opposed to the parasympathetic's classification as feed or breed. Feed or breed is really talking about where our activation and energy is going to be used. Fight or flight is preferencing our core body organs being able to increase their work. So the heart has an increased workload, it's beating faster, it's beating stronger to increase our blood pressure. The lungs are opening up so that we can have air flow through the lungs to meet our needs of oxygen making its way to the cells that are doing work. But when we're in our parasympathetic dominant mode, we're basically selecting to turn those mechanisms off so that we can shift blood flow and energy production to areas like our brain and our gastrointestinal tract. An interesting note, when you've learned about diseases that involve some form of shock, especially talking about the type of shock called inadequate organ perfusion, when we're talking about those things, notice that most of those will have a side effect or a symptom associated with vomiting or nausea. Well, the reason for that is if the person is in a sympathetic dominant mode and the fight or flight response is activated, we don't really have any energy or time to process food in our GI tract. And so if food is present when a person has their fight or flight response activated, even if they're not running for anything, they're just sitting in front of the TV and that's activated, they often feel nauseous as we turn off the GI tract, the parasympathetic nervous system. We turn off the GI tract so that we can preference our muscles and blood vessels, lungs, and major organs. So that's essentially the tie to that symptom. So when the patient is experiencing that, it's likely that they have some form of adrenaline dump and they're trying to activate some of those mechanisms to keep them alive in the presence of an illness or an injury. Though this isn't the only reason for nausea and vomiting, certainly could be tied to other illnesses that the patient has experienced at the same time. Parasympathetic nervous system structure is a little bit different. The preganglionic neurons have dendrites and cell bodies that are in that gray matter. Remember that dendrites and cell bodies are basically always gray matter, and our axons could be gray matter or white matter dependent on what's around the axon, meaning our myelin sheath or our Schwann cells. The parasympathetic preganglionic neurons are going to terminate in the parasympathetic ganglia that are located, as mentioned, in the cervical vertebrae and the sacral vertebrae. And those are going to have effects on the abdominal and thoracic cavity for our visceral effector communication. Another term that we can associate with our autonomic nervous system divisions is based on which neurotransmitter is dominant. So in the pre- and post-ganglionic neurotransmitter of the sympathetic nervous system, we have acetylcholine as our primary neurotransmitter. And because of that, that gives rise to the term cholinergic fibers from acetylcholine. You should have some recollection of this term because a medication at the EMT basic level that continues and is used actually more at the paramedic level is atropine, which functions as an anticholinergic, meaning that it basically will dial down or stop the acetylcholine response from sending the parasympathetic nervous system to be dominant at that point. And it could look like it has the effect of turning up our sympathetic nervous system, but that's not what's happening. When we give a medication that blocks, say, acetylcholine, it does not at the same time in the same medication also turn up the sympathetic nervous system. Instead, what we're seeing when we give a patient, for example, atropine, and their heart rate elevates, is the sympathetic nervous system functioning as it's trying to with the parasympathetic nervous system dialed down. So it could be, if you needed to have more of a response, certainly the sympathetic nervous system could turn up even more, but an anticholinergic doesn't do that. It just decreases our parasympathetic fibers. And that's an important thing for the paramedic as well, because you'll need to make the determination of which of the things in complex patient conditions do you want to address. It may be that you don't want to turn on and activate a heart that's full of coronary artery disease and is essentially a heart attack waiting to happen by giving them a medication that activates and turns up the sympathetic nervous system. And a point of your treatment may be to turn down the parasympathetic nervous system and let the sympathetic nervous system just kind of be wherever the body is putting that setting at. Now, the adrenergic fibers for our sympathetic nervous system comes from not the pregangliotic acetylcholine, but the postganglionic release of norepinephrine, which is also known in especially the European Union as noradrenaline. So adrenergic is coming from adrenal or adrenaline. Know all of these terms, and so let's recap them very quickly. The sympathetic nervous system could be known as certainly the fight or flight, as the adrenergic nervous system, and as the thoracolumbar nervous system. Whereas the parasympathetic nervous system, known as the feed and breed dominant, would be known as the cholinergic nervous system, and could also be called the craniosacral nervous system. All of those terms essentially interchangeable for our discussions. This is a picture showing basically those different neurotransmitter communication sites for our sympathetic and parasympathetic ganglion. It also shows relative length compared to each other of both the pre- and postganglionic axons. In green here, we can see that we have acetylcholine in both postganglionic neurotransmitters. We have green here for the parasympathetic postganglionic neurotransmitter, and red for our norepinephrine, as abbreviated here as NE, as our postganglionic sympathetic neurotransmitter. So how does all this work? Remember back to the idea early on in medicine, you were taught that our body is basically trying to seek balance. And so our body's always dynamic. It's always moving. Things are always working. We only become static when we die, and all of our cells have died as well. That's the ultimate point of being stable. So hemodynamics and hemostatic is basically related to the idea that we have essentially a scale, and the scale doesn't generally get balanced and sitting perfectly in the middle for very long. We have external and internal inputs that are going to change the way the scale needs to be responded by putting different weight on each side of the scale. And a scale is a good way to look at the autonomic nervous system. On one side of the scale for homeostasis, you'll have the autonomic nervous system's parasympathetic response, and on the other side, the sympathetic response. And throughout the day, minute to minute, sometimes second to second, the balance is going to change. At one point in the day, you may have no need for your sympathetic response to be activated. So everything is essentially running on a little sympathetic and a lot of parasympathetic. And then, I don't know, I'm about to jump in a car here in a few minutes and I'm going to drive through Albuquerque's traffic. I'm probably going to be turning on my sympathetic nervous system as I become angry. But my parasympathetic nervous system didn't turn off. It just was dominated by the sympathetic nervous system. So in that sense, when we're dealing with disease, we're looking for which imbalance do we have, and we're going to find a way by treating the patient, at least in that point in time, to get the balance back into an orderly position. So as the autonomic nervous system tries to find that balance, many of the organs that we have, or in this case for this terminology, the visceral effectors, are innervated with fibers from both sides, and that gives rise to our two divisions. Some disorders associated with sympathetic and parasympathetic are actually pretty common in our field for both us to experience and for the patients that we see. Stress-induced disease is a killer of first responders and has been for years. It's actually one of the reasons that's given rise to all of the increases and gains that we've had in fire department and even fire station structure, in which instead of having a blaring siren go off every time you get paged out at 3 o'clock in the morning when you're dead asleep, as was when I was there, now the tones will go off and the lights will gradually increase and the sounds will gradually increase to gradually move you out of that sleep state. The stress induction is going to release epinephrine or norepinephrine into your system and has an impact on your body, especially if it's done over long periods of time. Stress-induced disease is high in our line of work partly because of this. So examples could include heart disease and coronary artery disease, digestive problems, a lot of folks have that in our line of work, and reduced resistance to disease, a huge problem, all three of them, for our line of work given what we're faced with every day. The moral of the story on this last slide here is actually personal. So it's really easy for you to go through a 2-week course in which we talk about how to take care of yourself and then come out of that not taking care of yourself. That course was not designed to solve your problems. It was designed to give you tools to help solve problems in your own world years into the future. So now that you have learned some of the things about the well-being of the paramedic, which is the same as the well-being of the EMT, it's up to you to try and find tools to manage this right here. When we go to calls, there's no secret that we're seeking adrenaline in the job that we have. And we have adrenaline responses multiple times throughout every single shift when we respond to different calls. That's very unhealthy if we don't have a means of managing that stress. So I hope that with this knowledge, certainly you'll be taking better care of your patients, but I hope that you'll take better care of yourself. What's not on this list is that stress-induced disease also has associated with it mental health issues that arise now and in the future. And I'll tell you, I don't know anyone that's been in the field for any period of time, a year to 20 years, that doesn't have a mental health issue that's arisen from varying degrees of severity. That could be prolonged and excessive stress by itself. It could be PTSD and suicide. Whatever it is, you know that this is likely to happen to you, and nobody is above this. So now is the time, as you're entering your career, to work on stress-relieving activities and finding ways to manage the stress that you experience, both in our jobs and sometimes when they do studies and say firefighters and police officers and nurses and physicians, all of these folks included along with us in EMS, sometimes it's easy to say, well, it's their job that causes it. Sometimes they forget, though, that when we get off duty, we still have all the stresses that other people that have PTSD, that don't work in the line of work that we do, and are suicidal in some cases and don't work in the line of work that we do. We have all of that on top of what we get at work. So we're much higher at risk for these diseases.